their exam, because it's the stuff that they might get examined on in the written part, not the practical part. But as it's CasCare teaching nonetheless, it seems worthy to offer it around. So what's changed and why do we need to talk about it? So there's a quick reminder: these are the three groups of drugs that are carried by mountain rescue. So group 1. So this is one that all CasCarers should be carrying these drugs in their kit pouch, bought a load of drugs and left them at base. So if you haven't got these drugs, then I'd advise that you either just buy for pennies paracetamol, ibuprofen, and aspirin, or pouch. I'm pretty sure has got some left over in base that you can collect. Aspirin, it's only one tablet. They're 300mg tablets, so you don't need to take a whole strip of aspirin. Just take 1 or 2 aspirin tablets. Get a strip of paracetamol, a strip of ibuprofen, and some glucogels. So these are the drugs that you carry yourselves in your own kit. So if you arrive first, you can immediately administer these drugs safely as per your CasCare certificate. Group 2 is more advanced drugs that are carried by the team as a whole for the use of the CasCarers. So that's salbutamol, that's GTN, morphine, all the rest of them basically. The group 3 is a selection of drugs that still is carried by the team, but they're there to be administered outside of the remit of the CasCare syllabus, and they're for healthcare professionals to administer. So that's some forms of opiates. There's an antibiotic there, and there's a couple of other things that I can't quite remember. And the reason why this has changed is that fentanyl used to be a group 3 drug. I've got to say, Pouch's new appearance is far better than his old one. Group 3 drugs used to include fentanyl, which is a form of analgesia, so it's an opiate-based drug for providing pain relief. But over time, there's been a lot of sort of observational data that's been collected that's concluded that it's a safe and reliable and effective pain relief, and so therefore, rather than restricting this medication to medical health care professionals, it should be extended so that all CasCarers can give it. So that means that this is now, if the team wish to stock it, this is now a drug that any CasCarer can, on the new formulary. On the new CasCare syllabus, any team member can now begin to administer. Some of our team will have to retrospectively go through some extra training to be able to administer fentanyl and do some extra skills. But the practicalities of this is that those of you doing your exam, your written question may well have a question about fentanyl. So I wanted to make sure that you were prepared. We aren't stocking this immediately, and probably for some time that'll need to go for us to talk about and see whether or not we're going to use it. It's entirely likely that we will end up carrying fentanyl. It seems silly not to, but it will take some legwork over the coming year or so to put us in that position. So here you go. So here's a load of text which I'll read out for you. But this is in the summary of the new formulary, the 2022-2024 formulary, and these are the bits that refer to fentanyl. So on the 1st of January, fentanyl has changed from Group 3 to Group 2. It's due to effectiveness, safety profile within mountain rescue, and ease of use and increased usage over other opiates. So a lot of teams are now preferring to use fentanyl rather than use morphine, and you can see why. For a simple lower limb fracture, why do an intramuscular morphine injection when you can use a fentanyl lozenge? CasCare certificate holders are experienced in the use of opiates already and management of side effects. So what does that mean? Well, you're already administering and trained to administer a class of drugs that's similar to fentanyl, i.e. morphine. So you know what to look out for, you know what the contraindications are for that particular type of opiate, and you know how to treat potential overdoses and how to be mindful of managing that drug. Okay, so you've done 90% of the work in terms of giving an opiate. All we're doing is giving a slightly different one as an alternative. There's no difference with any of the aspects of giving opiates, with the exception of an additional contraindication of anyone taking an antidepressant medication. So this is a contraindication that's been put in for fentanyl. I'll be completely honest. I've spoken to a couple of people and we've found it slightly peculiar that this contraindication has been added. Fentanyl is used by lots of teams throughout the hospital, and myself and all my colleagues included, we've never, and including anaesthetists who use this stuff liberally and very, very frequently, none of us were aware of this contraindication, and none of us check for it, and none of us will begin checking for it. So it's a little bit unfair, I think, that you've had this added pressure upon yourself, because antidepressants are an incredibly common drug with a significant proportion of the population being on them. And the other thing is antidepressants come in an enormous range of names. So there's a variety of categories of antidepressants. There's one main type, which is called an SSRI, of which, off the top of my head, I can probably name about 4 or 5 different named drugs: sertraline, fluoxetine, paroxetine. So it adds a level of complexity, because this is going to be another thing you're going to have to check. Either way, it's in there now, so you need to be aware that a red flag for this drug is people taking antidepressant medication. And the reason for that is that there's a rare, theoretically potentially significant interaction between that type of antidepressant and fentanyl. But it's very rare. Okay, so let's not stress about it, but just be aware that it exists. So current casualty care certificate holders should receive additional training on fentanyl lozenges if they've not already done so to deliver fentanyl in rescue scenarios. So that will apply to most of our team. For teams that possess fentanyl, training can be part of normal casualty care scenarios, and these can be assessed in the practical part of the examination. So I don't think Aberglassant carry fentanyl. They may or may not do, but either way, the new SAR lot need to be relaxed that you will not be examined in your practical scenario. Your opiate of choice for your practical exam should be morphine intramuscularly, because that's what you're trained to give. So there shouldn't be any issue with that. For teams wishing to introduce fentanyl onto the back of this change of formulary group, additional training sessions should be held for all current casualty carers as above. So, well, that's what we said before. So we'll have to go through and do separate training if this ever goes through. For teams that do not possess fentanyl, there should be theoretical training with the casualty care course, but the application and use of the drug will not be. I've just said that. And questions around fentanyl may occur in the MCQs. That all makes relative sense. Any questions at this stage? No. So what is fentanyl? So fentanyl is essentially a man-made opiate. So it's the same category of drug as morphine. It's far, far more potent than morphine, 80 to 100 times. And its initial license, certainly in the UK, was for breakthrough of cancer-related pain. So it's a very, very effective, short-living pain relief. With a similar side effect profile, but often less. It's a bit of a less dirty drug, so it has some of the less. It tends to have less of the side effects, dose-related side effects that giving morphine might do. It's very commonplace in medical practice, but why it's developed a bit of a name over the last couple of years is that because of its potency, it's a highly abusable drug. So it's becoming a big problem in terms of drug abuse, and certainly I'm sure some of you will be aware, in America there's a pandemic of fentanyl use that's causing multiple deaths. From that story, those of you who are on Twitter and other such websites, there's been a lot of activity in the past year or so about police departments reporting that their staff have been exposed to fentanyl, they've inhaled it, or they've touched it, and they've become ill or died from it. this is not something that happens. This is a widely discredited rumour. So if you do read about people becoming ill from being exposed to fentanyl, please don't think that we're suddenly handing you out sort of pots of polonium to go and hand to other people. This is a safe drug. You will come to no harm from handling fentanyl. Okay. So this is its place in the formulary. So we'll just go through it bit by bit. So indication relief and moderate to severe pain, exactly the same as in morphine. Inclusion criteria: anyone over 18 years old. So that's actually different, isn't it, from morphine? So we've got a lower dose range for morphine. If you remember, there was some chat triggered by Mike Jones earlier, some point last year, about how we administer smaller doses of morphine, and so we could administer small doses through our smaller syringes to children of morphine. So this drug is therefore not suitable for under 18s. So that would mean that for our paediatric population, that morphine will still be our drug of choice. Exclusion criteria include known allergy to fentanyl, patient taking any antidepressant, children less than 18 years old, an injury to the mouth. The reason for that, I can only assume, is because this is given what we call buccally, so it's given into the membrane around the mouth, and it's absorbed through the mucous membranes in the mouth. So we're not swallowing this drug. A low respiratory rest, so less than 10 breaths per minute, or clinical signs of shock. Again, that's the same as morphine. Or head injury with a GCS equal or less than 10, or at below P on an AVPU scale. So that's interesting. So I don't know if that used to be on the morphine, but that's a very low GCS, isn't it? That suggests that you could give it to someone with a GCS of 11, but GCS of 11 is potentially a very impaired GCS. Anyway, so caution or need for further advice. So pregnancy is a caution. Oxygen saturations are low. Chest injury, although it caveats the point that pain can inhibit breathing. So if pain is stopping breathing, it may well be that treating the pain allows breathing to improve. And head injury, there is a range of potential situations where head injury may well be suitable. The dose is a lozenge, an 800 microgram or a 400 microgram dose. It's given buccally, so it's rubbed on the inside of the cheek for approximately 15 minutes. And it can be repeated for a total dose of 1,600 micrograms, or that's 2 lozenges, whilst we're caring for the casualty. Side effects are similar to morphine: respiratory depression, worsening shock, drowsiness, nausea and vomiting, and pupil constriction. May be worth considering giving an antiemetic alongside this drug, as most of us do with morphine, to preempt that nausea. So competency, so you need casual care certificate because you need to be able to identify potential overdose, and also to be able to administer naloxone. So naloxone, airway management and breathing support are all vital skills you must have to be able to administer a opiate. And that's it. The other thing that is more of a pain in the neck for predominantly pouch and to a lesser degree me is that it's also a Class A drug, so it has to be kept under multiple locks and keys and fixed to base with a clear audit trail and gets reported to the Home Office. So in the same way that morphine is this sort of thing that we parade around and all bow our heads to and very respectful for, because if we cock up our morphine stock, then MRAW gets in the neck from the Home Office, and you don't want to be that team that causes that. Fentanyl would fall into the same category as that, so we have to be incredibly careful with its storage and its documentation. Okay, what's it going to look like? So It will depend on the individual brand that is obtained when it's bought, but it's going to essentially look something like this. So a stick with a drug on the left-hand side of it, as the picture shows, with a range of different dosages, all color coordinated. We're going to use it as per our pain ladder, which I'm sure you're all fully aware of now. So the World Health Organization pain ladder, where you start at the bottom with our simple pain relief. We combine our simple pain relief together before we start adding in our more potent drugs. So it would never be fentanyl by itself. Put paracetamol in. If ibuprofen isn't contraindicated, add ibuprofen in, and then add in the fentanyl. The drug classes can be mixed, so you could give a fentanyl lozenge and then you could top it up at a later point with morphine if you so wished. There's nothing to preclude you doing that, but you obviously just have to be vigilant about potential overdose and side effects. So this would be a typical protocol that we might see. So pain score first. Work out the pain score. If it's moderate to severe pain, consider using buccal fentanyl. Is there a contraindication? If there is, then so these are the two contraindications where it sort of says that you can potentially use it cautiously. So head injury with GCS of 15, or chest injury with no or very mild low oxygen levels. Mild shock, I'm not sure what that means. I have to have a look at that. I'm not sure that we typically grade shock in our team. Anyway, if it's a contraindication, we don't give it. If there is, if there isn't, we consider using it. We explain to the casualty we're going to use a lozenge. It's a strong painkiller. It's absorbed from the inside of the mouth. So if you swallow it, it reduces the dose. The reason for that is that the blood supply that takes blood away from your stomach and the blood that takes blood away from your mouth into different circuits. So the blood that leaves from your stomach, which would be the blood that would be taking the dissolved and the absorbed fentanyl, goes straight to the liver, where it's then broken down, and the drug is broken down extensively in the liver. So before it actually gets to the rest of your body, if it ends up in the stomach, it will end up being broken down predominantly. So you essentially will get a much smaller dose. So what we want to do instead is we want to bypass that blood flow system, and we want it to be absorbed into the blood predominantly in the mouth, where it will go straight into a different circulatory pathway that will allow it to get to the place where it needs to go to. So unwrap. So here it says ensure naloxone is available. So again, dispelling one of the myths that I know circulates within the team. You don't have to have naloxone drawn up to be able to give an opiate. Okay, you don't have to have things drawn up. You just have to have it, within your not arm's reach, but within your physical reach while you're assessing that casualty. Okay, so unwrap the lozenge, rub it gently up and down the inside of both cheeks whilst twirling the stick for about 15 minutes. Observe for 15 minutes, monitor vital signs. If there are vital sign issues, stop and consider giving naloxone. If there are no vital sign issues, then continue and consider repeating it if required. So we're not using it if there's antidepressants on board, so that would be part of our sample that we give out. Features of shock, so it talks about some features of shock, which isn't really the scope of this conversation tonight. So here is would be a schematic of what we might put within the team to offer. So that's likely what we'll put with our kit if we ever administer it. Any questions from you guys? That's pretty much it in terms of fentanyl. It's nothing particularly exciting or wow.